Hi guys, so this video is going to be a demonstration of how to do a set of vital signs on your patient. For the purpose of this video, we're going to be doing an oral temperature with a digital thermometer or an electronic thermometer, but please refer back to your module and textbook for instruction on how to do body temperature for rectal, tympanic, and axilla temperatures with paper thermometers and using the various types of thermometers. So prior to coming into the patient's room, I have checked my patient's baseline in the chart, and I have washed my hands, done my 2-minute hygiene, and I've introduced myself to Lindsay, and I have checked her armband to verify that she is who she is with her two identifiers, a name and PPRN number or birth date. And so we're going to get started. So I'm going to start first with your temperature.
Okay.
So, Lindsay, have you had anything hot or cold to drink in the last 15 minutes or so?
No, I haven't.
Okay, so if your patient had anything hot or cold to drink, you want to make sure you wait at least 15 minutes before doing their temperature. And so with the digital thermometer, you would just remove the probe and put a probe cover on. And then the thermometer is going to go into the side of the tongue, back into the sublingual pocket under the tongue. And it usually takes about 5 seconds to 1 minute. On the digital thermometers, usually not 1 minute, they're pretty fast. And so you wait for the beep, and Lindsay's temperature is 37.3. So a normal temperature for an adult is 36.0 to 38.0. Anything 38 and above is considered a fever. So just keep in mind that if you are at 37.5 and upward, that you should be reporting that because you're nearing fever numbers. Okay, make sure that you discard your probe cover into the garbage can when you're finished, and then reinsert your probe into the thermometer. For a temperature, for an oral temperature, you don't need to wear gloves. Okay, so then we'll move on to pulse. So when you're doing a pulse, you want to use your index finger and middle finger. Never use your thumb because it has a pulse of its own. So you can just sort of take your patient's hand like this, and you're looking for the radial artery, which is on the thumb side. And you're just going to feel just behind the thumb with the pads of your two fingers, and press firmly enough to feel the pulse, which I can feel right here. And you're going to measure that for a full minute. So every tap on your fingers for a full minute. So a great way to do pulse and respiration sort of together is to have the patient sort of cross their arm over their chest, and you would have your watch for timing, and you're going to feel their pulse for the 1 minute. And then when you're done feeling the pulse after that minute is over, don't announce that you're finished, just start watching your respirations. And this way the patient is unaware that you are watching their chest rise and fall, and they won't subconsciously change their breathing pattern or hold their breath. So I'm going to just demonstrate both. So I'm going to measure the pulse for 1 minute. And 1 minute is up, and I'm going to do the respirations. And 1 minute is up. So when you're measuring the pulse, so Lindsay's pulse was 80 and her respirations were 14. Normal pulse rate is anywhere between 60 and 100, and normal respirations for an adult is anywhere between 12 and 20. So when you're checking the pulse, remember that you're looking for that rate, quality, and rhythm. And you want to make sure that it's regular, which is your rhythm. Quality, is it weak? Is it bounding? Is it and is it regular? With the respirations, you're looking for the quality of their respirations, the rate of their respirations, and the depth of their respirations. So, are they really taking big, deep breaths? Are they wheezing when they're breathing? And what is the pattern? Is it a regular pattern or is it an irregular pattern? So you want to make note of all these things when you're checking vital signs. The numbers are important, but so are the other observations that you make. And then to do oxygen saturation. So this is a saturation monitor or a pulse oximeter. And what you want to make sure of when you check oxygen saturation is that the person's hand is warm to touch. They have no fingernail polish on, and that their nail beds are nice and pink. Because if the hand is cold or the nail beds are blue, this monitor will not accurately pick up what the accurate saturation is. So what you want to do is turn your machine on, and you'll get a reading of 0 across your screen. And then when you open up your finger clip, where the light is, the light goes on top of the fingernail, not underneath. So that's going to measure right through the fingernail. So you have to make sure that the light is on top of the fingernail. And you're going to hear it's going to beep. And when you get a steady reading, that's when you're going to take that reading. So a reading for oxygen saturation should be anywhere between 90 and 100. Anything below 90 is a concern. Ideally, we'd like to see it above 95, so anywhere between 95 and 100. So Lindsay's oxygen saturation is 96, so that's great. Just remember that the oxygen saturation is not a standalone assessment. She may be 90, she may be 100%, but still could be struggling to breathe or breathing heavily. So you need to take in the observation that you make with their respirations and the rate of their respirations along with this. This is never a standalone assessment. Okay, and then we move on to the blood pressure, which is usually the most difficult part of the vital signs to master. It does take a lot of practice, so we will be practicing it a lot. So for the blood pressure, what's important for the blood pressure is that whether or not you know what the patient's baseline is. So I'm going to demonstrate both ways. So for the one-step method is when you know what your patient's baseline is. So I've looked in Lindsay's chart and I've talked to her, and based on the trends that I see in her chart, her normal is usually around 130 systolic. So that's the number that I'm going to use for my baseline for her. So I can use the one-step method for measuring blood pressure. So when you look at your blood pressure cuff, you see the arrow on the cuff where it says artery. That arrow you want to make sure is placed directly over the brachial artery. So to find the brachial artery is on the opposite side to the radial artery where you measure pulse. So it's on the pinky side, and you're going to come up to where the elbow crease is, and it's sort of just below that crease. If you sort of wiggle your fingers into where the tendons, you need to kind of wiggle your fingers in, and I feel it right there. People's anatomy different people's anatomy may be a little bit different. You might have to go a little bit higher or a little bit lower to feel, but for Lindsay's, it is textbook right below that crease. So I'm going to take my arrow and place it right over top of where I can feel the brachial artery. You want to make sure for blood pressure that the arm is bare. There's no tight clothing or any sweaters that you're putting the blood pressure cuff over that could alter the reading. So her brachial artery is there, and you see the arrow. So you want that blood pressure cuff to be about 1 inch above the crease, or 1 inch above the where you feel the brachial artery. Make sure it fits snug. You don't want it too loose. You should be able to get a couple of fingers, but you want to make sure that your equipment fits the patient properly. If the cuff is too big or too small, it will alter the reading. So make sure that you have the right size equipment. Okay, so I know her baseline is 130. So what I'm going to do is inflate my cuff to 30 above what I know her baseline is. So when I pump up my cuff, I'm going to pump it up to 160 on the gauge. So I'm going to have cleaned my stethoscope with alcohol swabs, the earpieces, and the diaphragm. And I'm going to make sure that my stethoscope is turned on so that when the stethoscope is in my ears, I can hear the tapping of my fingers. So you're going to put the stethoscope in your ears, and you're going to place the diaphragm of the stethoscope directly over where you can feel that brachial pulse, which is right there. Okay, you're going to make sure that your cuff is turned off so that when you pump, it will inflate. And you're going to inflate it to that number that you calculated, so 160 in this case. And you're going to let the cuff deflate about 2 to 3 millimeters of mercury per second. And you're going to take note of where you hear the very first sound and where you hear the very last sound. So that very first sound becomes the patient's systolic blood pressure, and the very last sound becomes the patient's diastolic pressure. Okay? So, if you do not know your patient's baseline, you have to use the two-step method that your module explains. So, to do the two-step method, the cuff gets applied the same way, but before you start to listen, you're going to find out what your patient's baseline is. So we need to calculate it. We don't know it. So we're going to, again, find that radial artery, which is on the thumb side with your two fingers. And there's her radial pulse. Okay, and you're going to turn your cuff off, and you're going to inflate your blood pressure cuff until you can no longer feel that radial pulse beating on your fingers. Okay. Okay. So for Lindsay, that was about 100 on the blood pressure cuff. So wherever the radial pulse cut off, that's you're going to add 30 millimeters of mercury to that number. So for Lindsay, I could no longer feel her radial pulse at 100 millimeters of mercury. So I'm going to add 30 to that. And so I'm going to pump my cuff up to 130. Now, this is what you do if the patient is a new admission, there's no vitals recorded in the chart, and or they do not know what their baseline is. So if you know nothing about their blood pressure at all, this is how you would determine a starting point. And so once you know that number, you would continue and check the blood pressure in the same manner that I just did during the one-step method. Okay. Once you're finished taking a set of vital signs, make sure that you clean all your equipment before you move on to another patient. There's usually wipes on the walls in most facilities, and you would take one of those wipes and wipe the cuff and the tubing all down, and the thermometer base, and the same with your pulse oximeter and your stethoscope. Okay, so now moving on to pain. So every time you do a set of vitals, you should do a pain assessment on your patient. Okay, so we're going to do a pain assessment using that PQRST mnemonic, or that PQRST-U scale that is in your module that we talked about. So we start with P, so that's provoking. So Lindsay, what normally, well, for starters, ask them if they're having any pain today. So Lindsay, are you having any pain today?
Yes, I am.
Okay, so start with if they say no, then you can let it be at no. If they say yes, you want to start with your PQRST. So P is for provoking. So Lindsay, what normally starts your pain? What normally initiates the pain that you're having? Anything in
Um,
particular?
After I've been laying or sitting for a period of time.
Okay. And does anything that you do make it worse or better?
Um, Taking Tylenol makes it better. Sometimes heat.
Okay.
If I move around too much, it makes it worse.
Okay. So now we know sort of what provokes her pain, what makes it worse, and what makes it better. So we're going to move on to Q. So Q is quality. So Lindsay, what does your pain feel like? Is it sharp, dull? Is it an ache? Is it like a stabbing pain?
It's more of like a throbbing pain at the base of my spine.
Okay. So Q is quality. So we know that the quality of the pain is like a throbbing pain. So we move on to R. So R is radiating. So does the pain stay just in your lower back, or does it radiate anywhere else, like down either of your legs or up the middle of your back or your shoulders,
Yeah, it radiates down my right leg.
down your right leg? Okay. So knowing where the pain moves to, where it radiates to, is sometimes helpful in determining what's causing the pain. So we know R. And S is severity. So, Lindsay, if 0 was no pain at all and 10 was the worst pain you've ever had, how would you rate your pain on a scale of 0 to 10?
Right now, I would say about a 5.
A 5. Okay, so that's about halfway. So, we're looking here at reporting this. We want to report this to our cover nurse so we can get Lindsay something for pain. Um, So S and T is timing. So I sort of asked that. I talked about that a little bit when I did the P, the provoking. But um, when is your pain its worst, Lindsay? Like, is it when you wake up in the morning, or what time? Is there a certain time of day that you feel the pain worse than others,
Usually in
or
the morning.
in the
Yeah.
morning? So maybe like sort of after you've laid in bed all night, or
Yeah.
okay. So, and then the module talks about you. So it's just asking them how it affects them. So how does it affect you? So how's this pain affecting you day to day and your
Well,
ability to get up and move and do the things that you need to do?
it's affecting my mobility. It's making my gait a little bit unsteady.
Okay.
And I find that I'm not as interested in my usual hobbies due to the pain.
Okay. And would you like me to ask my cover nurse if you're due for anything for pain right now?
That would be great.
Okay. So at this point, we're done the set of vitals. We've done her pain assessment, and we want to go and document everything that we have recorded accurately. We want to make sure that anything that is out of normal value is or away from the patient's baseline is reported to our cover nurse. And we need to report to our cover nurse that Lindsay is asking for something for pain. I did fail to mention when I did the blood pressure about normal ranges for blood pressure. So for the systolic blood pressure, it is between 90 and 140. And for the diastolic pressure, it's sorry about the interruption, but so for normal blood pressure value, so the normal range for systolic blood pressure is between 90 and 140 systolic and between 60 and 90 diastolic. So anything outside that window, or if it's beyond outside the window of what the patient's normal baseline is, should definitely be reported to your cover nurse.